This is part 2 of the perioperative lecture narrated by Lisa Shiver. We're going to pick back up with the intraoperative phase. During this phase, the nurse is the client's advocate because the client may be unconscious and not able to make decisions for themselves or maintain their own safety. So the nurse has got to focus not only on the patient's emotional well-being, but also on the physical factors such as safety, positioning, maintaining asepsis, and controlling the surgical environment. We'll start off in the holding area, and this is the area in the OR where the patient waits for entrance into a surgical suite. They may be monitored by that circulating nurse. The vital signs are going to be obtained. We'll continue doing assessments on the patient and watching for changes in condition. That IV also will be checked and maintained as well. This may be the area where the patient receives those on-call medicines that they will give prior to surgery. And again, those may include sedatives. They may be antibiotics if it's a high-risk surgery, such as GI surgery. The staff must perform a surgical scrub. And in this scrub, it involves removing all rings, watches, bracelets, any jewelry of any kind. Fingernails have to be kept short, clean, and healthy. Sleeves must end above the elbows. You can't have sleeves that come below the elbows. And the uniform needs to be fitted or tucked in at the waist. And that helps prevent contamination or things contaminating sterile field that maybe came in on the OR staff. The staff will apply surgical attire, which may include shoe covers, cap, mask, eyewear. Also, when washing or preparing to do the surgical scrub, they will turn on the water using knee or foot controls. They won't have hand controls like we traditionally do out on the floor. We'll wet the hands and arms under running lukewarm water and lather with a detergent soap to up to 2 inches above the elbows. To review the sterile scrub, make sure you look in your techniques book to see that procedure because it has recommendations of how long you scrub each side of the hand and between the fingers and things like that. Another important note is to keep your hands above the elbows at all times after a surgical scrub, or actually during the surgical scrub as well. Therefore, any contaminated water runs down towards the elbow and doesn't run towards the hand. Let's look a little bit further into the surgical gowning and gloving. Surgical attire should only be worn in the surgical suite. Most folks that work in an OR setting, when they come into work, they're going to change clothes and put on surgical scrubs that do stay there at the hospital. Street clothes are not to be worn in restricted areas of the surgical suite. Scrubs, shoe covers, hats, masks, protective eyewear will all be applied. Make sure you look in your techniques book on how to apply a surgical gown and glove because there is a process to doing that as well. There are many complications that can occur during the surgical process, one being hypoxia or the patient not getting enough oxygen, another one being the patient's body temperature drops or they become hypothermic. So there's some generalized things that can occur, but something that is considered an exception is malignant hyperthermia, and this only happens during surgery. Please note that it is a genetic disorder that's characterized by uncontrolled skeletal muscle contraction leading to potentially fatal hyperthermia. And what happens is the patient, when they're exposed to certain anesthesia, it causes their core temperature to spike. It gets really, really high, can increase up to 109 degrees Fahrenheit. But it's all induced by these anesthetic agents that we're giving the patient. And this is a genetic disorder, so it travels in families. So when the anesthetist is interviewing a patient prior to surgery, they may ask, well, did your parents ever have surgery or have any complications during that surgical procedure? And what he's trying to get at is there a history of malignant hyperthermia that maybe we don't realize with this patient? Malignant hyperthermia may occur 30 minutes into surgery or several hours after, and the body must be cooled or death will result. Emergency equipment, of course, would need to be on standby, and the true diagnosis is made with muscle biopsy, but sometimes we don't even have to do the muscle biopsy. We know just with the symptoms that this is malignant hyperthermia. The treatment is dantrolene. It is a medication we give IV, and it is a skeletal muscle relaxant. And that's one of the few times you would actually ever give dantrolene is with malignant hyperthermia. Of course, we're going to have to cool the patient. Probably going to do tepid baths, ice packs at all the axilla, the groin, things like that to help cool the body. Anesthesia is defined as an artificially induced state of part or total loss of sensation with or without loss of consciousness. So that's a real broad definition. It can produce muscle relaxation, block transmission of pain or nerve impulses, and suppress reflexes. What I want you to realize is there are many, many, many types of anesthesia. We probably are most familiar with general anesthesia when the patient is rendered unconscious, and we do that through IV drugs or inhalation drugs, and we have to ventilate, we have to support the patient respiratory wise, so they will be intubated and placed on a ventilator. With regional anesthesia, there are many, many different types, and what we're doing is just anesthetizing a local area. So we're just applying this to a certain region. It won't involve the whole central nervous system as it does with general anesthesia. How the doctor decides what he's going to use, one, it depends on the problem, but also we must consider the patient's age. Older adults may not be able to undergo general anesthesia due to other medical issues that they have. We have to consider, again, the health disorder that's present, pregnancy. Are they a smoker? Smokers would have trouble with general anesthesia since they will be placed on a ventilator. Is there alcohol use or any other drug use that might affect which type of anesthesia to use? So sometimes we have to consider those issues. And those are things that the anesthetist should determine when he comes around to interview the patient when they're still in the preoperative phase. I've got listed some of the different types of regional anesthesia, and this is a lot of information, but I'm going to pull out some of the highlights, some things you need to be able to remember. Spinals are used for surgery below the diaphragm, and there are some benefits listed there. The big ones are it does not require an NPO status because they won't be at risk for aspiration. There's no loss of consciousness, and this is really safer for older patients. I remember being a nursing student years and years ago, and I got to go into surgery, and I was very excited to get to do that. And my patient was actually having a toe amputated using spinal anesthesia. And the fact that the patient was sitting there talking to the physician while he was amputating her toe, and you could hear all the noises that are associated with that, it didn't sit well with me, and I had to be excused from the room, is all I'll say. But the patient is well aware of what's going on, but they feel nothing in the lower body. Complications with spinal anesthesia is that a headache may result due to a cerebral spinal fluid leak, and we may have to go back in and do a blood patch afterwards. That's where they actually draw some of the patient's blood and they will put it back into the cerebral spinal fluid to replace that fluid that's been lost, and that's called a blood patch. These patients do have to remain flat following surgery for several hours. A second type of regional anesthesia is an epidural. Probably most familiar with this, especially if you've had children and you had an epidural. Again, no loss of consciousness, which is wonderful. They don't have to be kept in PO. And we can prolong this anesthetic state because we'll leave the catheter in place so it continues to deliver medication. There are some risks though, such as paralysis and respiratory depression. And for the epidural to be administered, the patient may have to be in a lateral decubitus position or in a sitting position with their hips and head flexed, and that helps open up those vertebral spaces so the doctor can get the correct placement. Pain relief usually occurs within 30 to 60 minutes. And again, we have to be so careful if they have an epidural not to dislodge that catheter, because that catheter will be left in place, and that's why we can prolong this anesthesia. It also may be PCA controlled, where the patient is controlling the delivery of the medication. Of course, it will have a lockout. Excuse me. Other types of regional include topical, and that would be equivalent to taking a cream or a solution or ointment and applying it directly to the skin. Those are usually short acting. We could also do a local infiltration, and this is what we use when we are suturing maybe a laceration. The doctor injects lidocaine into the site. If you've ever had any dental work, he probably did a local infiltration and just numbed that area. Field block will anesthetize all nerves in a local area. So it's a little more broad than doing just a local infiltration, but it's going to numb all those nerves in one area. A nerve block targets a specific nerve, maybe the digital, the brachial, intercostal, and this is not immediate action. If somebody's having neck pain or they go in to get an injection of some kind, they're probably going in to get a nerve block, maybe because they have chronic pain to a site. There's also a bear block, and this one is interesting. It's short-lived, but what happens is the physician will have you place a blood pressure cuff. Say you were going to do this on an arm. The physician will place a blood pressure cuff on the upper arm. He'll inflate it, leave it inflated, and then inject the medication IV into that extremity. So it causes numbness of that extremity. And I've seen bear blocks used to reduce fractures, of course closed fractures. He may reduce them, and then once he's done, he just needs to do a real quick procedure. Once it's done, then of course you could release the cuff slowly. And that medicine does become systemic, but we usually use medication that has a very short half-life as well. Acupuncture is also considered a regional anesthesia, where we stick needles into specific meridians that connect to anatomic sites on the body. There are some advantages to this. The patient is not as sedated. There's no blood loss or very little. And there's a reduced need for pain medicines. But there are many different theories and opinions on how well that works. I personally am not a fan of needles. Then there's conscious sedation. And we've all heard of conscious sedation at this point, whether you've participated in it or not. It's very common in the emergency room or endoscopy when we do EGDs or colonoscopies. We'll use conscious sedation. We also use it a lot in the cath lab, maybe used in the OR setting as well. It's a short duration of controlled pharmacological depression of the level of consciousness. And we give medication. One of our more popular medications that we give is Versed, because we can reverse Versed really quickly. The patient won't remember a thing that happened during the procedure, but they're still able to follow commands. And that's one of the nicer things about conscious sedation. They still can follow commands. They're still awake. They usually won't have any respiratory compromise, but they're not going to remember a thing. You can give medications for conscious sedation, IM, IV, or also the nasal route. The most common is going to be IV. But with conscious sedation, it does require frequent, continuous monitoring by the nurse. You're going to have to be at that bedside with the patient one-on-one for a little while. Alright, now let's talk about the post-operative phase. This is the third and final stage of surgery, and it is divided into 3 distinct phases, which include the recovery room, or the post-anesthesia care unit, PACU, then the surgical floor unit, and then there's the post-operative phase, which is weeks, months to years after surgery. So even after the patient's out of the hospital, they are still in the post-op phase. The initial period, the patient will be returned to the post-anesthesia care unit, or the PACU, and the goal is to return to the baseline level of functioning. The problem is the patient's level of consciousness is probably going to be altered. So this does require close and constant observation. The patient is probably going to be extubated at this point if they were intubated. We will be monitoring their airway, their breathing, their circulation, and also their gag reflex. The client will be drowsy, dependent on other caregivers, and we as the nurse, the PACU nurse, will have our vital sign supplies, our stethoscope. They'll be on a cardiac monitor. We'll have our IV equipment and pumps. Suction equipment will be needed, may need respiratory slides or supplies, anything we will need to protect this patient's airway, breathing, circulation. Proper positioning is very important to ensure that airway. If possible, we may put the patient in a lateral Sims position, and this is on their side, just so they don't allow the tongue to fall back in their mouth and obstruct their airway. Now, there are some surgical procedures that won't allow that, so we may just have to turn the patient's head. We want to promote comfort and make sure the patient remains safe. The most important thing is going to be ABCs. That if they don't have airway, an airway, their vital signs really aren't going to matter. Or if their IV has gone bad, that's really not going to matter if they don't have an airway. You will receive a report from the OR team, which includes which medications were used during the surgery, if any blood was used, if there are any unanticipated complications that occurred, what they found during the operative and the preoperative stages. Are there any presence of tubes, drains, type of wound closures? You're going to get the full details of what occurred during the surgery. And they will also tell you how long the patient was in surgery. Once the patient leaves the PACU, they usually go to a surgical unit or to the floor. We continue to monitor them, and the protocol on how frequently to monitor them is going to vary from hospital to hospital. But generally, we'll be doing vital signs Q 30 minutes. The ABCs, again, are still going to be our priority. We may be doing neuro checks Q hour times 24 hours. Continue to monitor those IV lines and sites, provide wound care, monitor that dressing. Even if you're not doing a dressing change, you need to look at that site to make sure your dressing is not getting saturated with blood, or make sure the drains and the tubes and everything are where they need to be. You must look at those. Also, we need to assess the patient's comfort and pain level. And again, we taught them in the preoperative phase that we would be assessing their pain on the 1 to 10 scale. So we need to make sure we are doing that. Make sure your patient is always safe. Keep those side rails up and the call light within reach. And again, implement all that stuff we taught to them about in the preoperative phase, about turning, coughing, deep breathing, calling for pain medication. We want to keep those patients as comfortable as possible. There are many complications that can occur post-surgery. We tend to think about pulmonary embolisms and pneumonia and lung-related issues, maybe excessive bleeding, infection. There are many things that can occur. With the respiratory, of course, they're going to be at higher risk for atelectasis or aspiration, which can lead to pneumonia. Cardiovascular, we could end up with decreased circulation or numbness to an area, thrombus or clot formation just due to them being immobile, which could turn into an emboli. Neurologically, they could have some issues with prolonged sedation. Maybe they're not able to get rid of the medication as fast, and you may have taken care of a patient like this. They underwent anesthesia, but it just seems like it takes forever to get them back to their normal level of consciousness. Excessive bleeding and anemia can also be a complication. Of course, infection. Even though surgery is a sterile procedure, infection is always going to be a risk and a complication, and unfortunately it's way too common. Edema may occur at that incision, increased pain, wound dehiscence. Wound dehiscence is when the wound pops open, but there's still layers underneath that are intact. Evisceration is when the wound totally pops open and you are exposing external or internal organs, they may actually pop out of the belly. Psych issues may include depression or altered body image depending on the procedure that occurred. The GI tract may result in a paralytic ileus, or the patient may have nausea and vomiting afterwards. So many things that we need to watch for as the nurse post-op. With the wounds, most surgeons like to do the initial dressing change, and that will be anywhere from 24 to 48 hours post-op. It's going to be determined by, one, the physician's preference, but also what kind of procedure was done. Wound care may include wound packing, dressing, drains, ostomy bags, could be many things. What you as the nurse need to do is make sure you look at coat and breasts. And what do I mean by this is when you remove a dressing, you need to look at the dressing and inspect the dressing for color, odor, amount, and type. And what I'm talking about is drainage. What color is the drainage? What's the odor? What's the amount? And how much is, or what kind is it? What type is it? Then you're going to assess the wound. You're going to assess bleeding, redness, exudate, approximation, swelling, tenderness, and size. Those need to be documented in the patient's chart Q shift. Now, if you're only doing dressing changes once a day, you would only document the wound appearance once a day. Please keep in mind with post-op wounds, the patient may not be ready to look at the wound, so we don't want to force them to look at the wound or have to take care of a surgical wound immediately post-op. Also, we will medicate the patient before the scheduled dressing changes. So 30 minutes before we intend to go in there and do the dressing change, we may have to medicate them. Dehiscence, again, is an opening of the wound. It's superficial. That means there's still layers intact underneath. We still need to notify the doctor if a wound dehisces. That would be equivalent to having sutures, and the sutures pop open, but the underlying layers are still together. Evisceration is an emergency. This is when the wound opens and the internal organs are visible. They pour out of that, maybe the abdominal cavity. We need to return the client to bed if they're out of bed, obviously. Do not attempt to push the organs back into place. Leave them out. Cover them with moist, sterile dressings to keep them moist, and definitely notify that doctor immediately. Patient's probably about to head back to surgery. Monitor the vital signs. Keep the client as calm as possible, and you stay calm too. It's going to be scary if this ever happens to you, but keep in mind anxiety is contagious. So if you get out of control, your patient is as well. To control the patient's pain in the postoperative phase, they might be on a PCA pump, which stands for patient-controlled analgesia. The goal is to give them uniform narcotic serum concentrations so the patient can actually activate the pump instead of depending on the nurse to come in and give them medication at a certain time schedule. We use PCA pumps for those who require 24 to 48 hours of regular IM injections. That's a lot of shots to get in the muscle. The benefits are the patients get better pain control without oversedation, and we usually don't use as much narcotic when the patient has control over their PCA pump, believe it or not. Patients also feel like they have greater control, which is beneficial to them. And there are several different types of PCA pumps out there. There's a client demand. That means it'll only deliver the medication when the patient pushes the button. A continuous will give it a continuous dose, or it's not really continuous, but it'll give the patient a dose at certain set intervals, and that just occurs as long as that IV is in place. A continuous supplemented by client demand is the same thing as a continuous, where it's going to give them a certain amount every certain amount of time, but then the patient can also request more on top of that continuous dose. The most important thing, though, is you need to have Narcan on standby, because if the patient gets too much or starts to have respiratory depression, we will have to reverse the opiates with Narcan. Narcan is the antidote for an opiate overdose. There are lockout intervals built into the PCA pump, and this is defined as the time that PCA cannot be administered. And that's important too. You may be the nurse, or you may be the one setting up this lockout interval. Sometimes the pharmacy regulates this, and sometimes they leave it in control of the nurse. But you'll actually set how often the patient can get the dose, and it will not deliver it before that time period has gone by. There also are dose limits that will max out how much they can receive during a specific time. And then the PCA dose itself is just the amount to be administered each time the client activates or pushes the little button. We do need to teach the patient about PCA that pain should be tolerable but not necessarily absent. And we can get rid of most pain, but it's never going to be 100% gone. We do accept a tolerable level. Please let them know that there are safety features out there. Some patients are still afraid that they may overdose themselves. And there are alarms on the PCA pump also if we need to set those. Teach the patient how to control the button and release. It's just like a quick push as opposed to continuing to hold the button down. Report side effects that may occur, or monitor for side effects as well. And we may have to teach them to call us if they need to get up and move around in the room, because they're possibly going to be a little bit drowsy. The PCA pump also will record how many times the patient requests it, which I think is interesting, so you can monitor how many times the patient requested medicine. Doesn't always mean that they had medicine delivered. Narcotic analgesics, such as the opiate-based analgesics, may also be used in PO form. They may also be used in IM form. But these are generally the morphine, the Demerol, the codeine-based medications. They all fall under the opiates. These are the ones that can be reversed by administering Narcan. We'll use it to treat moderate to severe pain in short terms. It does cause respiratory depression, and it can suppress the cough reflex. That's why codeine is used so much in cough medicine, to depress the cough reflex. There are synthetic and semi-synthetic narcotics. Codeine is not the same thing as codone. Codone is actually a synthetic codeine. The first narcotic's been around for a long time, 350 BC. It was opium. Side effects with opiate-based narcotics: nausea, vomiting, constipation can occur, hypotension, respiratory depression is huge. I would say respiratory depression and constipation are two of the big ones out of that group. Some folks do suffer from nausea and vomiting related to opiate-based narcotics. Sedation is also another big side effect. With pain medication, we have to consider kids. It's harder to detect pain levels with children. And sometimes they might be scared of the treatment related to relieve pain. If the child knows that I might have to get a shot if I tell them I hurt, we might need to think of alternative routes to keep them comfortable, such as liquid dosing. With older adults, we need to consider they probably need decreased dosages. They're not going to need the same dose that possibly a young adult would need to control their pain, because they have a harder time metabolizing the medication and excreting it. We also see more pronounced side effects with older adults, and again we have to consider their renal and liver functioning as well. Also with children and the pain levels, don't forget about the FACES scale. With adults we can use the 1 to 10 scale, but little kids might have trouble with a 1 to 10 scale, so make sure you're familiar with what the FACES pain scale is. I want to mention morphine sulfate real quick. Again, this is one of our opiates. There are some other examples there of morphine, like imiscontin and roxanol. Those are both morphine based. They do cause depression of the CNS. There are many routes that we can give morphine. We have to be really cautious, especially if patients have asthma, respiratory depression, increased intracranial pressure, shock, and also cautious with respiratory disease or renal hepatic disease, like we mentioned earlier. Be careful with morphine in the elderly and also the young And the side effects again are listed there. Then there's good old Demerol. It is a synthetic narcotic we can use for short-term or severe post-op pain. It has no antitussive properties though, like the codeine does. It does come in the PO, the IM, and the IV routes. We need to monitor side effects such as nausea, vomiting, constipation again that can occur, and sedation. And then adverse reactions are listed there at the bottom. Just have a generalized understanding though of all your opiates. And please know that Narcan will reverse an opiate overdose. And there's Narcan. Narcan takes over the binding sites of opiate receptors in the CNS. We can give it several different routes, and something that's really unique about it, if a patient comes to the emergency room and they've taken something and they are unconscious, the doctor may order Narcan IV, and within a couple minutes after administering that, the patient will be sitting up and talking to you like nothing happened. That is if what the patient took was opiate based. So if a patient overdoses on opiates, we can reverse that in minutes with Narcan. It's pretty amazing.